Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show hosts or their guests are their own. Enjoy the show.
I'm John Strum, and this is RealTalk MS. It's July 2nd, and we have a lot to talk about. But now, if you choose, we also have a lot for you to read about. I didn't announce this in last week's podcast episode because I wanted to give it a kind of a soft launch, although a bunch of you caught it anyway. But as of last week and going forward, you can download a complete transcript of every Real Talk MS episode. You'll find a link to the transcript in each episode's show notes, and I know this is something that many of you have requested. It's something I've wanted to do for a while, so I'm glad to make it available to you. Do you ever wonder how or why your neurologist recommends one disease-modifying therapy instead of another? For some people living with MS, their first disease-modifying therapy is a mild drug with very few, if any, side effects. For others, their first disease-modifying therapy might be a more high-powered drug that carries a risk of more possible side effects. But how do neurologists really know when it's appropriate to use one specific disease-modifying therapy or even when it's appropriate to switch to another? My guest on the podcast is Dr. Ellen Mowry, an associate professor of neurology and the director of the MS Experimental Therapeutics program at Johns Hopkins University. Dr. Mowry has devoted her entire career to MS research, and her past research has led to breakthroughs in our understanding of multiple sclerosis. Now Dr. Mowry is the co-principal investigator of a nationwide research study whose outcome could have an impact on the treatment strategy for everyone diagnosed with MS. But before we get to my conversation with Dr. Mowry, there are a few other things that you should know about. I'd say that 2 out of the top 3 subjects that I received the most listener email about are stem cells and diet, as they each relate to MS. And this week, we have news about both. There's a lot of interest in the effect of diet on multiple sclerosis, and I'm regularly reminded by many of you that there are some diets that have been characterized as being quote-unquote good for MS. But we're never really sure of what that means, or who's doing the characterizing. One diet that's become extremely popular is the Wahls diet, named after Dr. Terry Wahls, who created it. After being diagnosed with secondary progressive MS, Dr. Wahls began researching food and vitamins, and she eventually created the Wahls Protocol, or the Wahls diet. The diet features lots of meat and fish, vegetables, especially green leafy vegetables, brightly colored fruits like berries, and fat from animal and plant sources, especially omega-3 fatty acids. On the Wahls diet, you don't eat dairy products, eggs, gluten-containing grains like wheat, oats, and rice, beans and lentils, tomatoes, eggplant, potatoes, peppers, and other nightshade vegetables, and sugar. Dr. Wahls claims that her diet enabled her to transition from using a wheelchair to riding a bike. Dr. Wahls even successfully completed an 18-mile bike ride. But what's been missing has been research that shows that the Wahls diet works for other people who are living with MS. And now, well, that's beginning to change. Dr. Wahls and her team at the University of Iowa just completed a small pilot study to determine whether adopting the Wahls diet for 1 year, along with practicing meditation, self-massage, physical exercise, and neuromuscular electrical stimulation, could improve fatigue among people living with progressive MS. The study included 18 participants with primary or secondary progressive MS, and after following the Wahls diet and other additional interventions for a year, the participants showed a reduction in their level of fatigue. They also showed a reduction in their body mass index, LDL cholesterol, that's the bad cholesterol, and triglycerides. Study participants also had a significant increase in HDL cholesterol, which is considered the good cholesterol. The research team concluded that diet influences a person's lipid profile, that is, the profile of fat in your system, and that lipid level influences the MS disease process and muscle function, which ultimately affect MS fatigue. This is a great first step that will hopefully lead to larger studies. The research team acknowledged that their pilot study was limited by its very small sample size and the lack of a control group and randomization. But if these results are reflected in larger clinical trials, then analyzing someone's lipid profile could be a step toward determining how to best treat their MS fatigue, a symptom that has very, very few viable treatments. And that would be a very welcome outcome. If you want to check out the details of this study, I'll include a link in today's show notes. And I'll also say that while I'm not a doctor and I don't even play one on TV, you probably don't have to wait for further clinical trials before you decide to start making healthy lifestyle choices. We're starting to see that diet, exercise, and if not exercise, at least physical activity can make living with MS easier. We're starting to see science that tells us things like obesity and smoking make MS symptoms worse. So my very non-medical and non-scientific conclusion is that you don't have to wait until a scientist tells you that you're better off living a healthy lifestyle. Making healthy lifestyle choices is a smart strategy for everyone, whether they happen to be living with MS or not. Even if your MS doesn't improve, at the very least, you'll avoid other health risks, comorbidities that will absolutely have a negative impact on your quality of life. So maybe in the case of subjects like diet and exercise, smoking and consuming excessive amounts of alcohol, we don't have to wait on science to confirm what is probably a very good idea anyway. A couple of weeks ago, I shared with you that a U.S. federal judge ruled in favor of the FDA in its lawsuit against a company that operates stem cell clinics whose highly questionable treatments have already blinded at least 4 patients. These shady stem cell clinics, and the majority of the hundreds like them in the United States, claim that they're unproven and unapproved treatments using stem cells that are derived from the patient's own fat cells can treat everything from arthritis to erectile dysfunction to Parkinson's disease, multiple sclerosis, and other chronic conditions. Now, there's no scientific evidence that this type of stem cell treatment works. The only thing that we know it accomplishes is that it's enabled the owners of these fraudulent clinics to collect millions and millions of dollars by offering false hope to people who are desperately searching for a cure. And I know that some of you listening have had this treatment, and others haven't had the treatment but would like to believe that it works. I think now you're going to have tremendous difficulty finding a clinic that will even offer this fake treatment. Because last week, that same judge issued a permanent injunction prohibiting this stem cell clinic company from offering this treatment. He also ordered the company, which operates 4 of these stem cell clinics, to submit to inspections of its facilities every 6 months by an independent expert for the next 2 years, and then annual inspections after that. The company will have to destroy any stem cell products that it might have, and can't resume these treatments unless the FDA gives it permission. And since the FDA brought the lawsuit against the company to begin with, I don't expect them to be granting that permission, well, ever. Acting FDA Commissioner Ned Sharpless talked about the court's action, saying, quote, "This sends a strong message to others manufacturing violative stem cell products." And if you're curious about what a violative stem cell product is, Dr. Sharpless went on to say, and I quote again, "There are many examples of companies deceiving patients with unsubstantiated claims about the potential for stem cell products to prevent, treat, or cure serious diseases. And in those cases, we are committed to acting to protect patients." He described companies like U.S. Stem Cell as, and I'll quote one last time, "taking advantage of patients, many in vulnerable positions with chronic or terminal diseases, by leveraging the widespread belief in the eventual promise of these products, flouting the statutes and our regulations." In other words, the federal court has made clear to the fake stem cell industry that exists in the United States that the FDA has the power and authority to shut them down. U.S. Stem Cell happens to be a publicly traded company, and the day that the judge issued his injunction, well, their stock closed at 8.5 of 1 cent in the over-the-counter market. And honestly, I consider that to be about 8.5 of a cent too high. I'm trying hard to just share this news with you without climbing onto my soapbox. But these procedures aren't cheap, and they aren't covered by insurance. So people are paying $10,000 per procedure or more for something that these clinic operators know isn't going to help them. And to me, that just represents a level of criminality, well, that should offend all of us. I know someone with progressive MS who has suffered tremendous loss because of their high level of disease activity and disability progression. They don't have very much in the way of material things or wealth. And all this person has been focused on for the past couple of years is finding a way to beg, borrow, or steal enough money so that they can go get this worthless treatment. And it breaks my heart to listen to them tell me how it's going to change their lives. If you've listened to the podcast before, you already know that I'm probably as pro-science as anyone can be. But this isn't stem cell science. These are nothing more than con artists selling something they claim is science to customers who are so desperate for any kind of relief that they believe them. They're the modern-day snake oil salesmen. And back in the day, a lot of those snake oil salesmen got run out of town or hanged. Now, if you'd like to review the FDA statement on the court decision, you'll find a link in today's show notes. One of the things that makes me more confident and comfortable when I think about treating MS more effectively is the research that my guest, Dr. Ellen Mowry, is currently involved in. It's likely that the outcome of Dr. Mowry's current study will have an impact on the treatment strategy for everyone diagnosed with MS. Dr. Mowry has devoted her entire career to MS research, and it was both an honor and a pleasure for me to talk with her. Now, I'll warn you that there are a couple of spots during our interview where Dr. Mowry's cell phone signal got a little wonky. Now, typically, I'd edit that material out. But there was just so much of value there that I left everything in. So I apologize in advance for a few moments where the audio quality suffers. But in my judgment, the information was just too good to not share it with you. In a moment, you'll meet my guest, Dr. Ellen Mowry. Dr. Ellen Mowry first performed MS research as an undergraduate biology major at Georgetown University. She began her MS clinical research activities as a neurology resident at the University of Pennsylvania, conducting a study of visual dysfunction and quality of life in multiple sclerosis. During her fellowship at the University of California, San Francisco, Dr. Mowry examined health-related quality of life in MS. Today, Dr. Mowry is an associate professor of neurology at Johns Hopkins University, where as the director of the MS Experimental Therapeutics Program, Dr. Mowry assists her colleagues with study design and helps oversee the conduct of MS clinical trials. In terms of her own research, Dr. Mowry's work led to the initial identification of the association of vitamin D status with relapse and brain lesion risk in patients with MS. Dr. Mowry also conducted the first pilot study comparing gut bacterial populations in patients with MS and healthy individuals. And today, Dr. Mowry is a co-principal investigator of an important clinical trial called Treat MS. And we're going to get to that in just a moment. But first, let me welcome you to the podcast, Dr. Mowry.
Thank you so much. I'm excited to be here.
Well, I thought that before we got into the Treat MS trial, we could take a moment to talk about vitamin D and MS. Thanks to your pioneering work and the work of others, we know that there's some sort of connection between vitamin D and MS, and that connection seems to be most easily illustrated by the fact that as we move further away from the equator and experience less exposure to sunlight, the prevalence of MS increases. And sunlight, of course, is a significant source of vitamin D. But once we get beyond that set of facts, scientific fact starts to get mixed with lots of what I'll call online opinion. And we end up with a lot of different beliefs about vitamin D and MS, along with some confusion about what is and isn't true. So at this point, what do we know, or what does the evidence at least suggest about the connection between vitamin D and MS, and what should people living with MS be talking to their neurologist about when it comes to vitamin D?
Yeah, that's an excellent set of questions. And I have to say the vitamin D story gets more and more complicated as time goes on. You're right. The first studies that suggested a possible role for vitamin D in MS risk came from the simple observation that the farther away from the equator people are, i.e. the far less sun that people get, the more MS occurs. And studies for a while were just doing sort of cross-sectional studies or asking people in retrospect how much sun exposure did you get. And of course, we know people with MS often have a program of several years where they may change their behaviors before a very frank set of neurologic symptoms comes out, to even include sun exposure reduction, because a lot of people don't feel very good in the sun. So those studies were really confusing. The best initial study looking at vitamin D levels and MS risk came out of the Department of Defense database over a decade ago. This was a really interesting study because people entering the military gave blood samples around the age of 18 and then periodically prior to being diagnosed with MS. And so they were able to look at the blood levels of vitamin D in those individuals who did eventually develop MS compared to people who did not develop MS, and showed that those with the highest levels of vitamin D were much less likely to later develop multiple sclerosis. However, it's really important to note that this was largely done in white or Caucasian individuals. There weren't enough individuals of other races or ethnicities to really form firm conclusions. And this is sort of backed up by a more recent study done out of the Kaiser system in California, in which it was a much more multi-ethnic cohort. And there they saw that, yes, vitamin D levels were associated with MS risk, but only in white people, in Hispanic or Latino individuals, as well as in African Americans. Vitamin D levels did not seem to be associated with MS risk. There is some suggestion that ultraviolet light exposure, however, may be important. And of course, it's possible that even in white people, the vitamin D level is just a marker of sun exposure. If that's the case, then perhaps we're chasing up the wrong tree, and supplementing with vitamin D won't help with either MS prevention or potentially outcomes in those already with it. We know that ultraviolet light may have its own immune modulatory properties, and also that even ultraviolet light exposure, i.e. going out in the sun a lot, might even be a marker of other healthy behaviors that are meaningful for MS risk. So I think there's still a lot of uncertainty, to be honest, surrounding the link between vitamin D and MS risk. Going back to the genes that we are born with, there are actually ways to genetically predict a person's vitamin D level, and this is a little bit less fraught with concerns about behavioral and other changes like that. And vitamin D genes, that prediction score, are actually linked with MS risk. So I think the jury's still out about what's going on there. In terms of people who already have MS, our studies have shown longitudinally that vitamin D levels are associated over time with relapse risk, as well as the development of new spots or MS lesions on MRI scan. And our studies of early MS showed that higher vitamin D levels were linked with less shrinkage of the brain, too, which we thought might be interesting, since shrinkage of the brain or loss of brain tissue is associated with long-term disability. However, in a group of individuals with longer-standing MS, that association did not hold. We're wrapping up our clinical trial, the VIDAMS trial, in which we're doing vitamin D supplementation at a higher dose compared to the recommended daily allowance. We're really interested in seeing whether vitamin D supplements in this randomized trial as an add-on to a platform MS therapy will be helpful. Two studies, although not published to the best of my knowledge yet, had reported out a couple of years ago, interestingly, that the vitamin D supplementation did not appear to affect their primary outcome, things like combinations of relapses and new MS spots. So the jury's still out. There's not a definite right answer. Studies to date have not really demonstrated a major harm associated with vitamin D supplementation in modest amounts. So I think that's very encouraging as we try to struggle through some of this heterogeneity and confusing signal from all these studies.
Well, thank you for at least untangling all of that and letting us know what is and still isn't clear. That in itself is helpful. But let's move on to the traditional versus early aggressive therapy for multiple sclerosis, or otherwise known as the TREAT MS trial. Now, this trial is actually taking on a pretty hot topic, an important topic among researchers, clinicians, and, of course, people living with MS, because everybody hopes that they're being provided with the best, most effective treatment to manage their MS. But choosing a therapeutic strategy or deciding to switch therapies is not a simple, straightforward process. What questions is the TREAT MS trial hoping to answer?
Yeah, so TREAT MS was really born out of my experience as a clinician, namely that when I am talking with somebody who's newly diagnosed with MS and they say, what's the right treatment for me? I have to pause and I have to try to make the best educated guess, because there's not really direct evidence to demonstrate that a specific treatment strategy is most effective. So like all of the studies that I design, they're generally studies that are born out of questions that the people living with MS ask of me that I think, gosh, we really should know that, shouldn't we? So we have a couple of main objectives in the TREAT MS trial. The overall objective is to say, overall, is there any benefit for people newly diagnosed with relapsing remitting MS to start with the strongest medicines right out of the gate, knowing that they may be associated with some increased risk in terms of how they're going to be doing several years out? Or is it reasonable to start with the milder, perhaps safer medications and then escalate or change to the stronger medicines if that first approach doesn't work? To do that, we are enrolling 900 people with newly diagnosed MS and essentially flipping a coin between the stronger MS medications and a more first-line medication, and evaluating whether that initial coin flip has an influence on disability at the end of the study. We are also really interested, though, in a few sub-questions. For example, are there indicators when a person is newly diagnosed that might be associated with higher risk? And if so, is that coin flip leading to a more substantial difference in longer-term disability in people with higher risk indicators versus lower risk indicators? So the way the trial is designed will help us answer that question as well. Perhaps there's not a one-size-fits-all approach, or perhaps there is, and that that the escalation approach or the stronger therapy approach out of the gate is totally reasonable for essentially most people with multiple sclerosis. Among people who look to have pretty mild MS at the beginning, if they are flipped by the coin to the milder medications to start with, a lot of times when that happens in clinical practice, and say a person has a new spot or one new relapse, and we think maybe we should switch medications, we're still not really sure. Can we get away with one of these other first-line medications, or is it time to increase yet again to a stronger therapy, potentially accepting more risk? And so to answer that question, we embedded within this study a second coin flip for the people with a very mildest MS who start off on a first-line medication. So if there are enough individuals who have breakthrough disease and need to switch in that setting, we may also be able to look at that treatment switch question too and help resolve that for our individuals that we care for with MS. We've been really excited about the study. I mean, it's so nice to know that that coming down the pike, we'll actually be able to look people in the eye and give them some evidence-based advice about what to do with their first MS medication.
Well, as you point out, this is a very large trial involving 900 people. It's taking place at around 45 different sites across the United States. Are you still recruiting participants for the trial?
Yes, we are. We've recruited about a quarter of our participants so far. So we have a ways to go, but we are steadily picking up individuals, and so are thrilled, and we're adding on a few more sites as well, trying to get a good coverage of the United States.
Tell me, who is eligible to participate?
Well, we really wanted to make sure that this study had broad applicability to people with MS in the future. So a lot of industry-sponsored trials traditionally have a lot of restrictions regarding who can participate in the study. Here, we really wanted to say, we want to take everyone who 5 years from now is going to walk through our door and ask us to advise them about medication. So basically, anyone with relapsing remitting MS who is newly diagnosed or untreated, essentially, even if they were diagnosed a while back, but needs to make a decision about their first therapy, will be eligible for the study, with a few exceptions. For example, if women are planning to get pregnant in the first few years, that sort of thing, probably enrolling in a trial is not the right avenue for that person. But in general, we're really taking all comers, as long as they're eligible to receive at least one of the stronger medications by safety criteria and have relapsing remitting MS. With no or very minimal prior treatment, they're eligible to participate.
And how long will someone be involved in the study, and what sort of things are they going to be involved in?
Yeah, so the study lasts for up to 4.5 years until the end of the funding period. And we designed the study to otherwise be very similar to the routine clinical care that people experience. So once the coin flip occurs and a person is randomized to either a first-line medication or one of the higher efficacy medications, the patient and their provider actually decides which of the medications within that class to start on. So there's a lot of autonomy that still remains in the study. And at that point, we do all the regular clinic things that occur whether or not a person is in a study. So they come into clinic, just a regular clinic visit every 6 months. We do MRI scans based on the consensus guidelines. So we sometimes repeat it at the beginning when people start a new medicine, but certainly 6 and 12 months afterwards, and then once a year as is recommended by consensus panels. At sites that do it as standard of care, optical coherence tomography or OCT takes place at clinic visits. The things that are not typical of a routine clinic visit but are done at those visits to minimize the impact or the sort of burden of time of our participants include what are called blinded examinations. So these are neurologic exams and other neurologic tests that are performed by study personnel who don't know about the person and what medicine they're on or what symptoms they've had, because those are our outcome measures. And so we don't want the knowledge of what a person has been through to influence how they interpret those results. Similarly, we also query people in the study periodically over the internet to answer some quality of life and other questionnaires. But in general, the study is considered a pragmatic trial, so it really kind of takes advantage of routine clinical care to minimize the additional burden on the participants.
And there's some financial compensation for people who are participating in Treat MS. Is that correct?
Yes. So we recognize that there's a burden on the participants to spend, an extra couple of hours at clinic visits that otherwise might be shorter, or to take the time out of their schedule to answer questionnaires. And so it's not a huge amount of money, but we compensate people for that extra time. For example, at our center, there's an hourly parking charge. So adding on 2 extra hours of clinic time really may be difficult for some individuals. So using the small amount of money that's available, it just acknowledges the expenses that people may incur by participating and hopefully compensates them for that.
And I guess it bears repeating that this trial is not introducing experimental medications or treatments. All of these are the approved treatments currently in use for managing MS.
Absolutely. We have a study advisory committee that consists of stakeholders as well as the neurologists who are running the study at each site. And if new medications are improved, we also fold those into our study protocol as well, so that really it's as up to date as possible and allows people in the study to choose the medication within the class to which they're randomized that seems the most appropriate for them.
Well, I'm hoping that as people are listening to this, they're recognizing the value of participating in this sort of research in terms of helping to provide guidelines that don't exist today, that will make the future selection of the right therapy evidence-based instead of best guess-based. So how can someone get more information or find out what the next steps are to participate in your study?
Yes, that's a great question. So we are available. You can find us on www.clinicaltrials.gov. We also have a website through the BIOS, BIOS group. So if you type in BIOS and Treat MS, you should be able to find us there. And of course, we do have an email address, treatms@jhmi.edu.
And I'm going to make sure to include links to those websites as well as the email address in today's show notes. So it'll be easy for people to just look at the show notes, and with one click, they can find out more information. Well, Dr. Mowry, I'm not even sure how to thank someone for dedicating their entire career to MS research. I like to say that I have the honor of talking with difference makers on this podcast, and you pretty much define the term difference maker. The Treat MS trial is only the latest example of how your work improves the lives of people living with MS. So thank you for all you do. And thanks for taking the time to talk with me today.
Well, thank you, John. I always think of our mission in working with people with MS as kind of a group effort or a team effort. And it also involves all the folks like yourself who disseminate knowledge, as well as the people living with MS who are so courageous in working with us to resolve some of these really important questions.
Well, that's going to wrap up this episode of Real Talk MS. If you haven't subscribed to the podcast, consider this your invitation to do so now. Subscribing to Real Talk MS is free, and it's an easy way to make sure you catch every episode. You can find Real Talk MS wherever you find your favorite podcasts, including Apple Podcasts, Google Podcasts, Spotify, Pandora. And if you have an Amazon Echo or Echo Dot at home, well, you can just say, Alexa, enable the Real Talk MS podcast. I'm John Strum. Thanks for listening, and we'll catch you next time.